otherwise proved, always you have to consider spinal muscular atrophy as the first important diagnosis because, as you know, it is the commonest condition which we will see in a hypotonic infant. And other common DDs you have to look is the congenital hypomyelinating neuropathy, congenital myasthenic syndrome, congenital muscular dystrophy, congenital myopathy, metabolic myopathy like Pompe's disease, syndromes like Zellweger syndrome, and Prader-Willi syndrome. Prader-Willi never forget because it is one of the important conditions we are nowadays seeing in a hypotonic infant uh, like an SMA patient. So SMA, Pompe's disease where treatment is available, Prader-Willi syndrome, congenital muscular dystrophy where CPK will be elevated, myopathy CPK will be elevated, congenital myasthenic syndrome, as you know, there is a uh, morning or periodic evaluation will be there. Congenital hypomyelinating neuropathy is extremely rare condition. So clinically also reasonably you can differentiate, but always you should think about spinal muscular atrophy, which is the commonest condition where genetic testing is required. So what is spinal muscular atrophy? It's a single gene disease, monogenic disorder. And the pathology or a diagnostic point in spinal muscular atrophy is homozygous deletion in exon 7 of SMN1 gene. Second most common lethal recessive disease, carrier frequency is 1 in 50, incidence is 1 in 10,000, and it is an autosomal recessive inheritance. So which test we will do for spinal muscular atrophy? Since it is a deletion of exon 7, SMN1 gene, you have to do the test called the MLPA. Not NGS, not sequencing, not karyotype, nothing. The test is MLPA, which will help to detect deletions and duplications. And the pathognomonic feature or the diagnostic point of SMA is homozygous deletion of exon 7 plus or minus exon 8 in SMN1 gene. So when you are getting a report, there will be SMN1 gene and SMN2 gene will be there. Both copies will be given. For the diagnosis, don't look into the SMN2 copy. Look into the only SMN1 copy, which will be 0 and 0 in SMN diagnosis, SMA diagnosis. If it is 1, 1, it is carrier of SMA. 2, 2 or more than 2, it is not an SMA. They are normal to SMA. Then you want to know that whether child is having SMA type 1, type 2, type 3, or you want to correlate with your clinical finding. Then you look into the SMN2G, exon 7 and exon 8. If it is 0, 1 or 2, it is SMA type 1. And 3 and 4, it is SMA type 2. 4 or more than 4, it is SMA type 3. Roughly, but 95% genotype phenotype correlation is there. So PGs always you should know how to diagnose a report if somebody has given you in DNB. Sometimes DNB people even now they can give DNB people or MD also because it's a very common test we will do. So first you have to look at the SMN1G, whether it is homozygous deletion or not. Then for the phenotype, you have to look at the SMN2G. So what are the points we will touch upon in the genetic counseling? One is counseling regarding the natural history of disease and prognosis, depending on the type of SMA. The type of SMA is basically based on the clinical phenotype. When is the onset? What is the progression? A child presenting at 3 months with recurrent respiratory infection, severe is always type. Whereas child is presenting as 1.5 years, 18 months, 2 years, with mild means motor developmental delay, scoliosis, etc., later developed scoliosis, or 5 years child is developing in his type. And always look for the genetic type. And treatment options, here treatment options always you have to link it. Recently developed options and limitations of various types. Levetiracetam, Soligasma, Nusinersen, whatever drugs are available, what are the complications of the drugs, or what are the limitations of the drugs, how much effect is there, everything you should be able to counsel. Then always multidisciplinary care is important because they are having a multiple complications from respiratory care, physiotherapy, orthopedic care,
എന്താ
everything you have to take. Hello?
താഴെ
And prenatal diagnosis, CVS at 11 to 12 weeks, and the DNA testing will be done. Before that, career screening we can do in previous child affected, extended family screening, consanguineous marriage, and nowadays we are doing in a general way. Most of the couples also we are coming to the genetic clinic. I am not telling that it's a universal screening. Genetic clinic, if somebody is coming for some counseling because they are consanguineous or previous child with some disease, we are looking for that disease, we will then look at the SMA also because SMA, as already we have discussed, carrier rate is very, very high. It is 1 in 50. So there is high chance to have anybody can be a carrier for SMA. So better to do a carrier screening. For carrier screening also, we will do the testing MLPA. MLPA can detect the carriers also. Then we can recommend the CVS for detecting the prenatal diagnosis. Anything you want to know about the SMA? Any doubts? Okay. So then we will go to the third case. A couple came for genetic counseling. So there we have discussed a condition where it is 100% of cases will have the same type of mutations, like SMA, where all are deletions. Whereas here you see that a couple came for genetic counseling. Their first child affected with a hematological disorder and was on recurrent blood transfusion since 8 months of age. Died at the 2 years of severe pneumonia and cardiac failure. Were not able to give blood transfusion for 3 months because of some family issue. They are concerned about the recurrence risk of the similar disorder in the pregnancy. But problem is they have not done any genetic testing. Okay. So what will you do in this patient? So if this is a patient like mental retardation or something else, very difficult to pinpoint the diagnosis. But for thalassemia, you don't need a genetic testing for diagnosis of the patient. Diagnosis of the patient can be reasonably done with the phenotype, with the blood test. So you have done evaluate all the reports. You have evaluated the report. It is classically looks like a thalassemia major, and hemoglobin electrophoresis shows that hemoglobin F at the age of 1.5 years is 80 or 90, with the hemoglobin A2 3.6 or something. With the hemoglobin A is very low. Almost we know that it is thalassemia major. There is no doubt. Then what will you do? You want to prove that it is thalassemia, but you don't have any blood of the baby. What you can do is you can do the carrier status of the parents. Carrier status of the parents you can done by simple estimation of the hemoglobin A2. Hemoglobin A2 more than 3.5 percentage in the absence of iron deficiency anemia tells that the parents are carriers. So you have done the carrier status of the parents. Both the parents' hemoglobin A2 is 4.2, 3.8, 3.9 something. That means both of them are carrier. So most probably or almost sure we are dealing with thalassemia in the previous time. But we don't know the mutation. Here is the problem. In SMA, we don't require because we know all patients are having same mutation. But here, more than 300 mutations are known. So if you do the genetic testing in the prenatal, and if you miss the mutation, you will say that baby is not affected. So we have to make sure that what is the mutation in the baby. But baby's blood sample is not available. But we know that thalassemia, unless otherwise proved, both the parents will be carriers. So we are already proved that parents are carriers. So you can do the blood testing of the parents. You can identify what type of mutation they are having, whether they are having IBS 15G2C or 619 base pair deletions, etc. Definitely they will be carrier for that mutations. Identify the mutations, then tell them that what's the recurrence risk? Recurrence risk is 25% since it's an autosomal recessive disorder. Then you do the prenatal diagnosis in the next pregnancy, identify the mutation, whether baby is affected or not, or a carrier, heterozygous or not affected. So, because in thalassemia, more than 200 mutations know, which can be in the transcription side, non-side splicing, insertion, frameship, various types of mutations are there. So, entire beta globin gene sequencing has to be done, not MLPA. Here we will preferably do sequencing because commonest mutation is point mutations in the intron, that is IBS, intervening sequence. That is intron 1 is the commonest mutations we will see. Common mutations are IBS 15G2C, 619 base pair deletion. For these are the 10 mutations common in our society. So you can do Sanger sequence. So there testing is MLPA. Here testing is Sanger sequencing. The ARMS PCR and dot blot are previous tests which will identify these common 10 mutations. But nowadays, ARMS PCR is almost same costly as Sanger sequencing because you don't have to learn that. But some standard examiners previously worked in CFC or something, they will ask, what is ARMS PCR, what is dot blot, etc. Because last 20 years, India is running on this ARMS PCR and dot blot because thalassemia is a very common problem in India. So now Sanger sequencing is very easily doable, and its cost is only 2,500 rupees. for beta globin gene sequencing because it's only 3 exons are there. So thalassemia, Sankar sequencing of the parents, identify the mutation, prenatal diagnosis can be done. So genetic counseling, mutation testing in the couple to confirm that both of them are thalassemia carriers and identify the mutations. If you identify the mutations, recurrence risk in the next pregnancy is 25%. If they are worried, prenatal diagnosis can be offered at 12 weeks of gestation by CVS, fetal sample to be tested for the identified mutation at the parents. If it is a homozygous or a double heterozygous, it is affected baby. Heterozygous baby is a carrier but not affected with the disease. No mutation identified, baby is not affected. So we will counsel like that. And if the baby is affected, we will say that baby is affected, baby will have symptoms like previous baby, and if sufficiently early be diagnosed, they can have an option of termination. We will not say go and terminate. Termination is the decision of the couple. We will only tell that baby is affected and baby will have all symptoms of the previous baby. And heterozygous, and we will say that baby is not affected. Carrier, we are not considering as a disease because there are so many people with the carrier status, we cannot do termination. No mutation identified, not affected. One more thing you have to counsel is you have to counsel that you have tested only for thalassemia. Rest of the diseases, genetic diseases or birth defect, anything you don't know. Because background risk of 2 to 3% of other sporadic genetic mutations, sporadic diseases still is there. You can do the other screening methods and ultrasound, etc., which will reduce that 3% to 1%, but still never it is 0%. That means genetic testing for thalassemia you have done doesn't mean that you are getting a certified non-genetic abnormality baby. Inverted commas normality. That we cannot guarantee. We can only say that baby is not affected with the thalassemia major by doing these tests. That also you have to counsel. So anything anybody wants to ask these two cases?
Shankar, regarding the both parents, there are two mutations, two types of mutations, and affected baby. There are two possibilities. You said homozygous or this thing, double
Double heterozygous.
heterozygous. In the double heterozygous, according when for the counseling, you always consider affected and severe situation. Okay. But is there a possibility of a double heterozygous? The severity may not be that severe. Is there a possibility of a homozygous very severe situation and double heterozygous of varying severity depending upon the
Mutation.
effect, mutation in the father and mother? Is there a possibility of some of the genetic mutations less severe? That's possible.
Perfect, sir. But it is not a standard statement that is not correct. That is, double heterozygous is milder and homozygous is severe. But if it's thalassemia you consider, the thalassemia severity is based on various factors, and one of the main factor is the type of mutations. Thalassemia mutations are classified as beta zero mutations and beta plus mutations. So, commonest mutation is IVS15G2C is a beta zero mutation. So, most of the time you will see a IVS15G2C homozygous mutation, which you will see as a severe phenotype. But if you see one person is having IVS15G2C and another person is having a capside mutation, which is a beta plus or beta plus plus mild mutation, the patient will have a thalassemia intermediate phenotype. So that is why we are telling we have to confirm the disease in the proband ideally. So if the proband is also having the same disease, same phenotype we are expecting in this patient. We are not expecting a different phenotype because there also it was thalassemia major. So here also it should be thalassemia major. And depending on the what type of mutations also we know it is a thalassemia intermediate mutation, that we will check it out. So the previous mutations I have shown you, these are the common severe mutations. That is first panel, left side panel, like IBS 15G2C, 619 base pair deletion, 4142 frame shift, IBS 11G2T, and codon 89. These are all severe mutations. Whereas CAP1 mutation, -25, -88 are milder mutations. So this, when, as you rightly pointed, double heterozygous of a one severe mutation and one milder mutation, baby will be milder phenotype. But that is not applicable to all diseases or everywhere. In thalassemia, that difference is there. That is why these double heterozygous patients are. So, similarly in thalassemia also, if you are homozygous for CAP1 mutation, you will have a milder mutation.
ಏ
So,
ಇದು
whether
IRCTC 380 ಅಲ್ಲ 440
it will not based on whether it is
958 ಆಗಿದೆ
homozygous or a
1344
double
ಕಟ್ಟ ಇತ್ತು.
heterozygous. Meghna, please mute yourself. Okay. So, it is not based on homozygous or double heterozygous. It is based on what type of mutations you are dealing. Okay, sir.
Ideally, proband severities need to be considered before taking the decision.
Perfect. And actually, sir, that's I told, always the proband phenotype, proband genetic testing, everything is required. Only in very common conditions like thalassemia, SMA, etc. Without proband testing, we will do the genetic testing in the parents. Sorry. Jumali George, any doubts? Jumali George, any doubt is there?
No, sir. No, sir.
No, your voice is breaking.
No,
I'm
sir.
not able to hear.
No, sir.
You please put into the chat box. Somebody will.
No
read
doubt,
for-
sir. No doubt.
Okay. So, any other thing anybody wants to ask? PG's ശ്രീജിത്ത് എന്തെങ്കിലും ചാറ്റ് ബോക്സിൽ ഉണ്ടെങ്കിൽ പറയണേ, എനിക്ക് ഇവിടെ കാണാൻ പറ്റൂല. മോഹൻദാസ് പറഞ്ഞാലും മതി ചാറ്റ് ബോക്സിൽ ഉണ്ടെങ്കിൽ. Okay. So now we will go to a little bit complicated case. This is a simple case we told thalassemia and SMA. This is under common condition, congenital adrenal hyperplasia. A newborn baby is positive for congenital adrenal hyperplasia and newborn screening program, further evaluated and confirmed as CAH by neonatologist and referred for genetic counseling. So first thing is confirmation of the diagnosis. You have to evaluate all reports. Elevated 17-hydroxyprogesterone, abnormal electrolytes and clinical finding. Treatment started with the hydrocortisone and fluorocortisone and molecular confirmation of diagnosis. Everything has to be done. Here, one point I want to tell, this is one situation where treatment is always more important than genetic testing, because it is a molecular diagnosis or a genetic condition with emergency. There is no need for genetic testing. Hurry is absolutely not required. If patient is sick, shocked, suggestive of congenital adrenal hyperplasia, at the earliest you have to start the hydrocortisone and fluorocortisone. You don't have to wait for any genetic testing in congenital adrenal hyperplasia. Genetic testing is required only for the prenatal diagnosis. Okay, so it is a emergency you have to do. So there are, as you know, there are various type of congenital adrenal hyperplasia. Commonest is 21-hydroxylase deficiency, which is a most common form of congenital adrenal hyperplasia. Autosomal recessive disorder, mutation in CYP21A2 gene, and every newborn with ambiguous or atypical genitalia without testis, clinically, when you evaluated for hydroxylase deficiency, potentially it's a medical emergency. Already we have proved. So here, interesting thing is, here you have got the sequence analysis also deletion duplication. So in thalassemia, I told you require sequence analysis because there are point mutations, various types of mutations. Whereas in SMA, it is deletion duplication. Whereas in CYP21, 20 to 30% is deletion duplication, 70 to 80% is sequence variations. So you have to do both the tests. You have to do the sequencing of the CYP21A2 as well as MLPA of the CYP21A2 to say that baby is positive or negative for the CAH. So usually we will follow a combo test for MLPA plus sequencing of the CYP21A2 for the things. And if 21-hydroxylase comes as negative, then we will do a next generation sequencing for all other genes, which is we have to look for 3-beta hydroxy, 17-alpha, 11-beta, all those things we have to check before branding a child is not having any mutation of any of the congenital adrenal hyperplasia. Most of the conditions with this combo testing, we will be able to prove it. So in genetic counseling, management of the baby with the hydrocortisone and fluorocortisone to prevent short loss in crisis. So if somebody asks you, this should be the first point. Since it's a genetic, don't jump into the conclusion that it's a genetic testing is required. First thing is treatment of the child. Shock has to be treated, everything. Then monitor. Then about the sex of rearing in the newborn period. If it's a congenital adrenal hyperplasia, you don't have to much confusion except in 3 beta OHSOD. Rest of the most of the conditions, sex of rearing will be female only. So you look for any testis. Testis is not palpable. It almost looks like a female with a mild clitoromegaly. It is congenital adrenal hyperplasia. To be certain, you can say that the sex of rearing will be female. And do a karyotype. Make sure that it is XX only. Then monitor serum electrolytes and 17-hydroxyprogesterone. Later, monitor growth, including bone age for titration. Always, they will have a recurrence risk for it. Recurrence risk in future pregnancy is 25%. Need to identify the mutation in the proband and confirm carrier status in the proband. It is mandatory. It is mandatory because CAH, as I told you, there are CAH phenotype is having 5 or 6 proteins with 6 genes, and each gene is having different types of mutational mechanism, different tests are required. So without confirming the disease, prenatal diagnosis cannot be done. And there also one major problem, I'm not going into detail, don't ask me because you will be more confused. There's a pseudo gene is there in CAH. So it is very difficult to do the testing also. A lot of difficulties are there. So make sure that you identify the genetic mutation. Then if you identify, prenatal diagnosis can be offered at 12 weeks by DNA testing to say that whether baby is affected or not. Just like thalassemia and SMA, we have told. Prenatal therapy, as a clinical point of view, now it is observed. Nobody is using it. It is acceptable only in the research setting or as a part of a research protocol. Routinely prenatal therapy with the hydrocortisone to prevent the clitoromegaly is not at all acceptable as a standard of care management in the antenatal period because of multiple reasons. So that you don't have to tell the patient. Somebody asks only, otherwise it is you don't have to tell about that. So anything about CAH? Srinivasan sir is there, Guru sir. Srinivasan sir.
Srinivasan sir is muted.
Yeah, I just now entered a little late, so
Okay.
first, yeah.
Next.
Okay, sir.
Because I was told 8:30, but I think it has started earlier.
Oh, sir, you is in US or Pondicherry?
USA
US, okay.
student. One of
Okay,
your
sir.
USA.
No, sir, you are my one of the first teacher, I can say. Okay, Guru. Okay. So any doubt for any PGs? So here also I think it is treatment is first important. Sex of rearing, most of the time it is female. Do a karyotype, confirm XX, monitor the electrolytes and 7-hydroxyprogesterone, start hydrocortisone, fluorocortisone, monitor growth, including bone age, then do the genetic testing, confirm the mutations, do the parental testing. Recurrence risk is 25%. Do prenatal diagnosis in next pregnancy. Prenatal therapy is not in the thing. So a couple came for genetic counseling in view of their child having a short stature. So I have put little bit easier. I have put a disproportionate limb shortening. But actually, if it's a short stature, a detailed evaluation is required because short stature can be not. Unless non-genetic causes are there, I'm not going to the details here that non-genetic causes. Even genetic causes can be a Turner syndrome, can be a chromosomal abnormality, it can be a growth hormone deficiency where it's a single gene disorder with autosomal recessive and autosomal dominant inheritance, or it can be a Noonan syndrome with autosomal dominant inheritance, or it can be a skeletal dysplasia. Various types of skeletal dysplasias are there with all types of inheritance. So short stature is a very major area. This is how I'm talking about only genetic. Non-genetic, so many causes are there. So that is a detailed evaluation is required. Make to identify the diagnosis, then only you can do the thing. They are concerned about here. I have just told because it's an achondroplasia like disproportionate limb shortening. They are concerned about the final stature and recurrence risk in the next pregnancy. So still they came with that. You have to start from the basic. All my postgraduate, please start from the basic. Take a height. Because even now in genetic clinic, they will come with achondroplasia. They will not take the height. PGs. Because they will feel that SAR knows that it is achondroplasia. Mutation has been done. But you have to learn from the starting. You have to take a height. You have to check what is the height. So several times you have to look into that. Okay, it's a 10-year-old child with 100 centimeter only. Okay, short stature is there. So repeatedly you do anthropometry only. You will be able to do the anthropometry by heart. Just hearing the height, you will be able to know that it is a 3rd centile or a 5th centile or 10th centile, or whether it's short stature or not, less than 3SD or less than 5SD. Repeatedly, you have to do for every patient, take height, mentally calculate, where is it, how. Every time you have to do it. Instead of that, you will see diagnostic cases, then you will feel that why should I evaluate all those things? Don't do like that. Take a clinical examination, detailed anthropometry, everything. Then skeletal survey, then check at the X-ray, then look for other causes of short stature because dysmorphism, everything you have to check it out. So in this child, we can see that small trident hand is there, typical X-ray findings of squared pelvis with a small sacrocytic notch. This typical upper femur is showing a hyperlucent area, very small long bones, etc. So it's achondroplasia. Achondroplasia, I think most of the people get diagnosed, but every skeletal dysplasia is not achondroplasia. That is very important thing you should know. Autosomal dominant, FGFR3 mutation, C1138G2A. So 50% recurrence in the offspring of the baby, but the parents are concerned about the next baby. So invariably, we have learned that autosomal dominant 50%, 50%, 50%. So you will say that 50%, but it is not 50%. Most of the achondroplasia is a sporadic mutation. So parents are having normal stature and child is having C1138G2A mutation and classical feature of achondroplasia. So we know that it is a sporadic type of achondroplasia, and a phenotypically normal parents, recurrence risk is negligibly low. And empirical recurrence risk is 1 in 400. That is 0.25%. So very low recurrence risk. They don't have to bother. So 50% recurrence risk when this child is male or female, when child grows and got married, their child will have a 50% recurrence risk is there. Or a couple is coming, father is achondroplasia, first child is achondroplasia, what is the recurrence risk? It is 50%. Mother is achondroplasia, father is normal, they are coming, they are asking what's the chance? We don't want to have the same child, then 50% recurrence risk. But their not phenotype is not enough, mutation in the proband, that is the father or mother who is affected, has to be done and confirmed. Because there are so many other conditions which looks like similar to achondroplasia that also you have to check it out. For example, very commonly we will see both the parents are short stature. So they will refer for genetic counseling. And most of the clinicians, simple routine clinicians, have short stature, achondroplasia, disproportionate short stature, skeletal dysplasia means achondroplasia. So the resident will tell or somebody will tell, or even gynecologist will tell me or phone, sir, 2 achondroplasia is there. Can I send for counseling or I am sending for counseling? And what's the chance of having an achondroplasia if 2 achondroplasia married? Any PG? Who is this John George? John George. What's the recurrence risk when 2 achondroplasia marry? ആരെങ്കിലും ഇട്ടിട്ടുണ്ടോ ഇതില് ചാറ്റ് ബോക്സിൽ?
ചാറ്റിലൊന്നും വന്നിട്ടില്ല സാർ, ഒന്നും
വന്നിട്ടില്ല. ഓക്കെ, ഇത് ഏതെങ്കിലും PG എന്ന് പറഞ്ഞാൽ ആരും വാ തുറക്കുന്നില്ല കേട്ടോ റിയാസെ.
അതാണ്
എനിക്കിവിടെ കാണാൻ പറ്റുന്നില്ല.
ഇതെല്ലാം സാറ് തന്നെ ഇവരെ പലതവണ പഠിപ്പിച്ചിട്ടുള്ള കാര്യങ്ങളാണ്.
അതെ അതെ. സോ രണ്ട് അക്കോൺഡ്രോപ്ലേസിയ, നമ്മുടെ എത്ര PGs പേരൊക്കെ കണ്ടു ഞാൻ, പക്ഷെ എനിക്കിത് കാണാൻ പറ്റുന്നില്ല. So
you can type in wrong answers also. That is okay. Participating in the class is important.
So when 2 achondroplasia marries, what is the recurrence risk? ശില്പയുണ്ടോ? ഏതെങ്കിലും ശില്പയുണ്ടോ? ഇല്ല. മെറിൻ ഇല്ല. ജോൺ ജോർജ്?
ഒരു ആൻസർ വന്നിട്ടുണ്ട് സാറേ ചാറ്റ് ബോക്സിൽ. ശ്യാമ answered as 50%. And Praveen Shelvaraj answered as 100%.
So both are wrong. Okay. So basically, you just draw a Punnett square. Whenever you have got a doubt in the examination, you just draw a Punnett square and see that what it is. It is 100%. Why it is 100%? Gayatri has told that 25%. So ideal answer should be 25% will be homozygous achondroplasia, 50% will be heterozygous achondroplasia, 25% will be normal. Okay. And interesting thing is, in achondroplasia, homozygous achondroplasia is severe and presents as a lethal skeletal dysplasia. So 25% will die. Just like thanatophoric dysplasia, they will immediately in the newborn period, they will die. 50% will be achondroplasia. So somebody has written achondroplasia. I don't know whether they want to say that achondroplasia is 50%, but affected babies are 75% basically. 25% is homozygous. They will die in the newborn period. 50% is a standard achondroplasia. 25% is normal. But you cannot counsel like that unless otherwise you proved that both the couples are achondroplasic and they are having the mutation of achondroplasia like C1138G2E. Most of the time, father will be achondroplasia and mother will have some other disease. Or mother will be achondroplasia, father will be short stature due to some other disease. So these two has to be considered as a different condition. One photograph usually I will show in this achondroplasia talk, that is father and mother both are short. Their mother was the achondroplasic, father was a growth hormone deficiency. So there we have to counsel that mother 50% achondroplasia, child is there, we can do the prenatal diagnosis. Father is an autosomal recessive growth hormone deficiency, but mother is not a carrier for that. So there is no chance of transmission of the father's disease to the child. So it has to be taken as separately. ഇത് ഞാനിവിടെ ഇട്ടില്ല എന്ന് പറഞ്ഞാൽ ഇത് ഞാൻ പറഞ്ഞല്ലോ വേറൊരു 40 മിനിറ്റ് കൊണ്ട് തീർക്കാനുള്ള ഒരു സ്ലൈഡ്സ് ആയിരുന്നു. അപ്പൊ അത് ഞാൻ ഇട്ടില്ല. സാധാരണ അക്കോൺട്രോപ്ലേസിയ മാത്രമായിട്ട് ഒരു കൗൺസിലിംഗിന്റെ ഒരു ഡിഫറെന്റ് സിനാരിയോസ് ഓഫ് അക്കോൺട്രോപ്ലേസിയ is there. So that is very, very important. Similarly, these people will ask whether can I do the ultrasound? Can I do the ultrasound for detection of the achondroplasia? Very, very difficult. Because achondroplasia short stature will occur only after the 22-24 weeks of gestation. So you can identify the achondroplasia or suspect achondroplasia after the time of termination of pregnancy. 24 weeks is the our legal time of termination of pregnancy. So ultrasound, you cannot detect and take a decision on pregnancy. So if they want to do that, you have to do the prenatal diagnosis. But this you have to discuss them in detail because as you know, achondroplasia is not a condition with the lethality. So you can, if they tell that, and both I have seen. There are some parents says that, okay, I am ready to continue the pregnancy or I don't want to do the testing. But one father and what a psychological trauma I have faced in my school days. Transport bus actually he is working in government press. He is working in government press. Wife is working in another government servant. Both of them are well educated and they are good in. But he told, I don't want a child with achondroplasia because I know he is intelligently normal. I am also working in government press, but I don't want to take the psychological trauma which I have faced during my school days. Always my friends will call me kulla. And transport bus because as we know, transport bus in the step of high. They cannot, achondroplasia cannot get into that. So these type of their feelings, their concern, everything you have to consider when you are doing the genetic counseling. So that is about the achondroplasia. Any doubts? So anticipatory management of achondroplasia you have to do. Take what are the complications, everything you have to ask. Short stature, final adult height is always nowadays newborn and achondroplasia diagnosed. So always they will ask what is the adult height. Adult height between 120 to 130. Males will be around 126, 128. Females will be around 122 to 124. That's the adult height without any treatment. Treatment for short stature, growth hormone therapy is not FDA approved. It is approved only in Japan for achondroplasia. Some benefit may be there, but disproportion will increase. Limb lengthening procedure like Elisarov techniques they can do after 5 or 6 years when child is cooperative, but it's a cumbersome technique, lot of difficulties. Evaluate and look for other complications like hydrocephalus and spinal abnormalities. If significant developmental delay and hydrocephalus complications are there, then you have to do prenatal diagnosis. It can be done. Why I put can be done, not like SMA or thalassemia. most of the time, we have to take the concern of the parents, then only you have to do it. Then, Shija, anything you want to ask? No. Okay. So, a 22-year-old nursing student came for counseling in view of her brother is affected with a progressive muscle disease with onset at 5 years of age and now in wheelchair. So, what is the phenotype? Phenotype, as you know, it looks like a muscular dystrophy, most probably Duchenne muscular dystrophy, because as you know, almost 80% of muscular dystrophy what we seeing is Duchenne muscular, and typical age group of 5 years, progressive muscle weakness, wheelchair bound at 16 to 18 years, most probably they are having a Duchenne muscular dystrophy. She was planning for marriage, but she's telling, I cannot bring my brother, or whether can I do the direct carrier screening. Direct carrier screening is not recommended because, as I told, not like SME, because muscular dystrophy can be due to multiple causes. So we want to confirm the diagnosis in the proband. Without that, if you do the genetic testing, you can say that you are not a carrier of DMD and your child is unlikely to get the disease. But you cannot say that you will not have the disease of your brother, because we have not confirmed the disease of the brother. So confirmation of the diagnosis in the proband is important. Examination and evaluation of all reports. We know that it's possibly a muscular dystrophy. It can be a DMD or it can be other muscular dystrophy. So for DMD and BMD, it's a mutation in the dystrophin gene. Deletion duplication is the commonest mutation, which is seen in 70%. Point mutation in 30%. So already I told you, deletion duplication always do an MLPA. So since we have 70% is deletion duplication, first test is MLPA. If MLPA negative, then you do the sequencing. NGS method can be done because dystrophin gene is a very large gene with 79 exon. Sanger sequencing, which we have told in thalassemia, is not possible to do in dystrophin. Is not possible. Previously, we were not doing it. But now, after the advent of NGS method, that is next generation sequencing, we can do sequencing of the dystrophic gene. Along with that, we can look for the other genes like LGMD gene, CMD, congenital muscular dystrophy gene, etc. Facioscapulohumeral dystrophy is very, very difficult to diagnose. It is having a separate type of test, which I am not going to tell here. Another important thing you have to suspect is the myotonic dystrophy. But myotonic dystrophy, it is a triple repeat disorder where you have the TP-PCR formatting. So muscular dystrophy is a little bit difficult, but first test you have to do is the DMD, followed by NGS. If you failed in both, then you refer to a geneticist or a higher center, because there you have to do some specific tests. Sometimes muscle biopsy will be required. High-end testing and things are required, which may not be possible in a pediatric center. That's the thing we can do. MLPA followed by NGS, confirm the diagnosis. And if the mutation is identified in the proband, deletion 48 to 51 exon, in this patient we identified the mutation, then carrier testing in the 22-year-old lady MLPA was done. So what are the possibilities the lady will be carrier? So the mutation is identified in the proband. So mother may be a carrier, may not be a carrier, because 33% of DMD is due to sporadic mutation, new mutations. If mother is a carrier, 50% chance that this nursing student may be a carrier. But now we cannot test the mother, because mother will be 50 or 55 years. She may be there, she may not be there. And she will also, unnecessary, we don't want to produce her confusion. If you identify the deletions in the brother, you can directly test the carrier testing in the 22-year-old lady. But if the lady or the sister is less than 18 years, we should not do the testing for carrier screening. There you can do the mother's testing. If mother test is positive, then do the carrier testing in the child when it is more than 18 years. And if she is positive, 50% of her male offspring will be affected. 50% of chance that her male offspring will be affected. Prenatal diagnosis can be offered at 12 weeks, CVS sample collection and DNA testing, counseling based on the result. Just like previously we told, if it is deletion is there, baby is affected. If it is not deletion, baby is not affected. If negative, no risk of transmission of disease, we don't have to do prenatal diagnosis. But you have to tell that, just like previous I told, this testing helps to identify only about the muscular dystrophy in your brother and the baby, whether the that disease is there or not, we can identify. Background risk of other genetic disease and malformation of 2 to 3% is there, that we have to counsel the parents. I think now it is 8:40.
Shankar,
I can take 10 minutes.
Shankar,
Yes,
about this scenario,
yes, sir.
whether an ultrasound can be done, and can we reveal the sex of the child if it's an in utero diagnosed to have a female? Can we avoid the genetic thing? Can we reveal this thing? Is it legally possible?
Sir, first thing is, the first point is better to not to do that, because in India, ideally it is not allowed. But real PCPNDT revision, they have told that in some of the X-linked conditions, if you want, you can do it, but that will always produce unnecessary issue, because that will be a. So we are telling as a PCPNDT person, we are told you should not do that. You should not do that. Better to avoid, because of multiple reasons. Number one, you are having a test which is definitely saying that it is maybe is affected or not. If that test is not available in 15 years back, when this test cannot be done, we used to do like that. We used to do like that. We are not doing it, but in Western countries or something, they are telling you do a karyotype, look for whether male or female, that will be confirmed. Because second issue is ultrasound never confirms the sex. There is always a chance of missing. It is a male. And when you are doing the ultrasound, the leg is in the flexed position. The scrotum and the penis you have not seen. Because in the ultrasound, what is happening is you will see the penis and scrotum. It is a male. If you are not seeing the penis and scrotum, they will say it's female. So if due to some reasons, കാല് മടക്കി വെച്ചിരിക്കുന്നുണ്ടോ ഇടയിൽ കയറി ഇരിക്കുന്നുണ്ടോ ചിലപ്പോൾ മെയിൽ സ്ക്രോട്ടവും പെനീസും കണ്ടില്ലെങ്കിൽ they may say that it is female. ഇപ്പൊ പറയാൻ പാടില്ല റൂള് ഞാൻ പറഞ്ഞേ ഇത് നമ്മൾ ഡിസ്കസ് ചെയ്യാൻ പോലും ഡിഫിക്കൽട്ട് ആണ് ബിക്കോസ് യു ഷുഡ് നോട്ട് ടെൽ ദാറ്റ് ഇറ്റ് ഇസ് മെയിൽ ഓർ ഫീമെയിൽ. സോ അതുകൊണ്ട് ഫസ്റ്റ് പോയിന്റ് അത് ബെറ്റർ ടു അവോയ്ഡ്, അത് ചെയ്യാൻ പാടില്ല. രണ്ടാമത്തെ കാര്യം തെറ്റു വരാനുള്ള സാധ്യതയുണ്ട്. മൂന്നാമത്തെ കാര്യം കുറച്ചുകൂടെ കൺഫർമേറ്ററി ടെസ്റ്റ് ഈസ് അവൈലബിൾ. സോ ഇറ്റ് ഈസ് നോട്ട് അറ്റ് ഓൾ റെക്കമെൻഡ്. പിന്നെ നമുക്ക് ഒന്ന് രണ്ട് കോർട്ട് കേസ് വന്നിട്ടുള്ളത് ഇതേപോലെ ഡെഫിനിറ്റ് കേസ് ഇല്ലാത്ത കേസുകളിൽ സെക്സ് ഡിറ്റർമിനേഷൻ വേണമെന്ന് പറഞ്ഞ് കോർട്ട് കേസ് വരെ വന്നിട്ടുണ്ട്. പക്ഷെ അതുപോലെ നമ്മൾ പാടില്ല എന്നേ പറഞ്ഞിട്ടുണ്ട്. ബിക്കോസ് ബെറ്റർ ടു അവോയ്ഡ്. അതാത് കേസിന്റെ മെറിറ്റ് അനുസരിച്ച് ഐ ഹാവ് റിട്ടൺ ദാറ്റ് ഇറ്റ് ഈസ് നോട്ട്. ബിക്കോസ് അവിടെ അവർക്ക് വേറെ ആക്ഷൻ അവർ പോകുന്നില്ല. സ്പെഷ്യൽ കേസുകളിൽ സെക്സ് സെലക്ഷൻ കേസ്, സെക്സ് സെലക്ഷൻ അല്ല എന്ന് പറഞ്ഞ് എന്റെ പേരെന്താണ് സെക്സ്, ചില സെക്സിൽ മാത്രം അസുഖം കാണുന്ന എക്സ്-ലിങ്ക്ഡ് റിസസീവിൽ മാത്രമല്ല, ചില അസുഖങ്ങൾ, ചില പൈറുവേറ്റ് ഡീഹൈഡ്രോജനേസ് കോംപ്ലക്സ് ഡെഫിഷ്യൻസി ഒരെണ്ണമുണ്ട്. അത് ഒരു സെക്സിൽ മാത്രമേ അത് മാനിഫെസ്റ്റ് ചെയ്യത്തുള്ളൂ ബിക്കോസ് ഓഫ് സം റീസൺ. അതൊക്കെ അവർ ബുക്കിനോട് കണ്ടുപിടിച്ചു. എന്നിട്ട് വക്കീൽ പറഞ്ഞു സെക്സ് കണ്ടുപിടിച്ചു കൊടുക്കണം, സോ ദാറ്റ് അഫക്ട് അല്ലാത്ത കുട്ടിയെ നമ്മൾ എടുക്കാം എന്നുള്ള രീതിയിൽ. പക്ഷേ അതൊന്നും നമുക്ക് അലോ ചെയ്യാൻ പറ്റത്തില്ല. അപ്പൊ അതുപോലെ നമ്മൾ കോർട്ടിൽ അതിന്റെ റീസൺസ് അവതരിപ്പിച്ചു. അത് ഗ്യാരണ്ടീഡ് അല്ല. അതങ്ങനെ പറയുന്നുണ്ടെങ്കിൽ there are few reports that even males can be affected. അപ്പൊ നമ്മൾ അഫക്ഷൻ ഇല്ലെന്ന് പറഞ്ഞ് മെയിൽ വന്നിട്ട് അഫക്റ്റഡ് ആയി കഴിഞ്ഞാൽ that will be a problem. സോ അതുകൊണ്ട് നമ്മൾ ഏത് കാരണവശാലും അതിനെ നിരുത്സാഹപ്പെടുത്തുക എന്നുള്ളതാണ് നമ്മുടെ ഇപ്പോഴത്തെ നിയമപ്രകാരമുള്ള തീരുമാനം. അതുകൊണ്ട് ബെറ്റർ ടു അവോയ്ഡ്. അത് അലൗഡ്. ഓക്കെ.
And another thing is, when you get the report, prenatal test report, it will be, if it is affected male, you will get it as hemizygous. And if it is carrier female, it will be reported as heterozygous. Isn't it like that?
Yes. Actually, previously when we are giving the reports, we were giving the reports as affected or not affected. So not affected means it may be a male with a not affected, or it may be a female. Because previously when we were doing the genetic prenatal diagnosis, it was like that. But nowadays, the different companies ഒക്കെ വന്നപ്പോൾ കമ്പനീസ് പലപ്പോഴും ഇങ്ങനെ അങ്ങ് റിപ്പോർട്ട് തരുന്നുണ്ട്, ഇറ്റ്സ് എ ഹെമിസൈഗസ്. പക്ഷെ ഡീറ്റെയിൽഡ് ആയിട്ട് വായിച്ചാലേ മനസ്സിലാവും. അപ്പൊ അറിയാവുന്നവർ വായിക്കുമ്പോൾ അത് മെയിൽ ആണോ ഫീമെയിൽ ആണോ എന്ന് അറിയാൻ പറ്റും. ഫീമെയിൽ ആണ് ചിലപ്പോൾ അറിയാൻ പറ്റും, ഹെട്രോസൈഗസ് ആണെന്ന് അറിയാൻ പറ്റും. പക്ഷെ അത് എക്സ്പ്ലിസിറ്റീവ്ലി ദേ വിൽ നോട്ട് സേ ഇറ്റ് ഇസ് മെയിൽ ഓർ ഫീമെയിൽ. നമുക്ക് വായിക്കുമ്പോൾ അറിയാൻ പറ്റും ചിലപ്പോ ചില കേസുകൾ. ഓക്കെ. So I will go rest of the cases in a little bit fast. Case 7, because ഇതുവരെ നമ്മൾ പറഞ്ഞ കൂടുതൽ കേസുകളും ഡെഫിനറ്റ് കേസുകളാണ്. അതായത് DMD, Thalassemia. അതിൽ നമുക്ക് ഡെഫിനറ്റ് ആയിട്ട് അറിയാം ദാറ്റ്സ് മ്യൂട്ടേഷൻ 100% പേഷ്യൻസ് എന്താണെന്ന് അറിയാം. But here you see the baby is 6 months old with the global developmental delay, microcephaly and seizure. Here it can be a chromosomal, it can be a monogenic, it can be mitochondrial, it can be non-genetic, it can be epigenetics, anything is possible. So here phenotypic evaluation is most important. Facial dysmorphism, other malformation, MRI brain, CT scan, genetic testing like karyotype, microarray, fragile X, whole exome sequencing, everything you have to do to reach a definitive diagnosis. And only after that you can do the prenatal diagnosis or counseling. Without that, very difficult to do the counseling. Because one or two example here, you can see that child is having a calcifications. Multi-gene panel testing shows it is a Achondroplasia syndrome due to RNAS HEC2C gene. It is an autosomal recessive disorder. 25% recurrences, prenatal diagnosis can be offered. See, because it's a single gene disorder. Whereas here, it is a facial dysmorphism malformation. There is a derivative extra material in the 17th chromosome in the baby. When we did the parental father chromosome, father is having 870 translocation is there. So recurrence. So it's a chromosomal abnormality with the parents is having a balanced translocation carrier. Here counseling is different. Previous child is an autosomal recessive disorder. Next maybe it may be a mitochondrial disorder. It may be something else. So here, depending upon the etiology, counseling totally will be different. So in these type of cases like autism spectrum disorder, mental retardation, microcephaly, these type of conditions, detailed evaluation required, then only you can do the counseling. So balanced chromosomal amniocentesis to be offered, IVF-PGD is alternate option. Then metabolic disorder, one metabolic disorder, 18-month-old child will not attain the milestones. On examination, child is having a coarse facies, thyroid function test normal, to be evaluated for mucopolysaccharidosis because as you know, coarse facies, genetic testing, always hypothyroidism is the first condition, but hepatosplenomegaly is there, corneal clouding is there, dysostosis multiplex is there. So you have to suspect mucopolysaccharidosis. We have to evaluate DNA analysis for confirmation, same enzyme analysis, DNA analysis, Sankar sequencing, MLPA in 10% cases because Hunter syndrome, 20% can be due to deletion duplications, multidisciplinary care, ortho ENT ophthalm, availability of specific therapy, ERT in MPS type 2 or a hemopoietic, everything you have to counsel. I will go a little bit fast because I think already 8:50. Genetic counseling depends upon same. Points are same. What is the recessive or MPS type 2 is X-linked recessive. Both parents carrier status, mother will be a carrier. Recurrent 25% in MPS type 1, 3, 4, etc. Here 50% offsprings. Prenatal diagnosis can be offered. CVS at 12 weeks. Principles are same. Only thing is what test you will do, how will you counsel, everything little bit different. And last case, a couple both having sensorineural deafness, deaf mute, came for genetic counseling. They are concerned regarding possibility of recurrence of similar problem in their offspring. It's a very common problem. So I told you 2 achondroplasia, what's the chance? Similarly, 2 deafness, what's the chance of recurrence risk in the baby? Anybody? Because that's a very common we are seeing. Selective mating. 2 deaf people will marry. What's the chance of recurrence? Both are having genetic deafness. That's also improving. Then what's the chance of recurrence? So if it is what's the commonest inheritance of recurrent deafness? Proban mutation. I don't answer. Okay. Okay. So important thing is mutations will be different. That is called the locus heterogeneity. In deafness, there are various types of mutations are there. So even if both the parents are deafness, genetically they will have 2 different diseases. One person will have GJB2, another person will have GJB6. So recurrence will be 0 because both are autosomal recessive diseases. If it is autosomal dominant, then it will be 50% chance of recurrence in the sibling is there. So there, the testing in the parents is mandatory. Recurrence in the offspring is depends upon syndromic or non-syndromic, what gene is involved, mode of inheritance. Everything has to be considered when we are telling the recurrence risk. And for example, so genetic testing of the couple for confirmation of the diagnosis and which gene is involved. Next generation sequencing we will do because multiple genes are, more than 100 genes are there. Depending on the gene involved, inheritance will vary. For example, husband is autosomal recessive gene GJB2, wife is autosomal recessive gene but GJB6. That is two different genes of autosomal recessive. Recurrence risk is no recurrences. Whereas husband is GJB2, wife is also GJB2, then it is 100% recurrences. So it is very, very important. And husband is autosomal dominant, wife is autosomal recessive, then 50% recurrences of the dominant gene. Recessive gene only when husband is a carrier, it will inherit, otherwise it will not inherit. Okay, so just if, depending upon the combination, it will vary. It is empirical recurrences you don't want, I think. So similarly, when you are counseling, always think about the isolated malformations like myelomeningocele. Myelomeningocele, most of the time, it is an isolated malformation with recurrences of only 2 to 3%. Also check for high risk factors like maternal anticoagulation and for anticonvulsants and diabetes, etc. Periconceptional folic acid will significantly reduce, around 70% reduction of next pregnancy affected. Targeted anomalies can detect the anomaly. No specific genetic testing is required. But only thing is, syndromic NTD has to be ruled out, like Charcot-Lewin syndrome, Meckel-Gruber syndrome. These are some conditions where NTD-like features will be there. Along with that, some other features will be there which suggest that it's a syndromic condition where recurrences may be high. So take-home message, the importance of detailed evaluation of the proband to reach a reasonable diagnosis. Confirmation of the diagnosis with the genetic testing is mandatory for the proper genetic counseling, including the prenatal diagnosis. The basic principles of genetics should be applied during the assessment and counseling. Genetic counseling should be a psycho-educational process which will help the family to not cope up with the genetic disorder and to take a proper reproductive decision. I think the 10 cases I was able to take you through. Any doubt is there, I will clarify. I don't know, I have do justification because Riaz told me in the 12 o'clock, I told just I will take this class because everybody will have some feel about the genetic testing. Thank you. And any doubt is there? Anything you can discuss, any doubts or any clarifications?
PG sir, you can ask doubt. ആരും ഇല്ലാന്ന് ചോദിക്കുന്നില്ല അല്ലേ? ആൻസറും ഇല്ല.
അത് ചോദിക്കുന്നില്ല, ആരൊക്കെ ഉണ്ട്. പേര് ഞാൻ കുറെ കണ്ടു, നമ്മുടെയും കുറെ പേരൊക്കെ കണ്ടു.
അശോക് സാർ ഉണ്ടല്ലോ.
ഉണ്ട്.
ആ സാർ എന്തെങ്കിലും കമന്റ്സ്?
ഈ ഹിപ്പോകോൺഡ്രോപ്ലേസിയ എന്നൊരു കണ്ടീഷൻ.
ഏതാ സാറേ?
ഹൈപ്പോകോൺഡ്രോപ്ലേസിയ, അതിന് ജനറ്റിക്സ് ഡിഫറെന്റ് ആണോ?
ജനറ്റിക്സ് ഡിഫറന്റ് അല്ല, മ്യൂട്ടേഷൻസ് ജീന് ഡിഫറന്റ് ആണ്, ഓട്ടോസോമൽ ഡോമിനന്റ് ആണ്. അതിന്റെ റെക്കറൻസ് റിസ്ക് ഇതേപോലെ തന്നെയാണ്, അക്കോൺഡ്രോപ്ലേസിയ പോലെ തന്നെയാണ്. ആൾമോസ്റ്റ് സെയിം, ബട്ട് ഇറ്റ്സ് എ മൈൽഡർ ഫിനോടൈപ്പ്. ഫൈനൽ ഹൈറ്റ് വിൽ ബി 140 സെന്റിമീറ്റേഴ്സ്. അവിടെ വേണമെങ്കിൽ നമ്മൾ ഗ്രോത്ത് ഹോർമോൺ കൊടുത്താൽ കുറച്ചുകൂടെ ഹൈറ്റ് കൂടും. സോ ഹൈപ്പോകോൺഡ്രോപ്ലേസിയ നമ്മൾ ഡയഗ്നോസ് ചെയ്യുകയും ടെസ്റ്റ് ചെയ്യുകയും ചെയ്യുന്നുണ്ട്. Patient will have a mild short stature, not like achondroplasia. ഈ ട്രൈഡ് ആൻഡ് ഹാൻഡും സിഗ്നിഫിക്കന്റ് പ്രോബ്ലം ഒന്നും കാണില്ല. There are some typical skeletal features to differentiate. Skeletal X-ray features to differentiate hypochondroplasia and achondroplasia. Genetically also different.
പോണ്ടിച്ചേരിയിലെ ശ്രീനിവാസൻ ഇപ്പോഴും ഉണ്ടോ അവിടെ? ശ്രീനിവാസ്
sir.
Still my classmate.
Sir, I think he is left. Okay.
My classmate from Jipmer days.
Okay.
Riaz is there? Riaz? No. ഇല്ല തോന്നുന്നു. അപ്പോൾ I think Shankar, we can wind up after. It was a very informative talk, at least for me.
Thank you, sir. Thank you, sir.
Anyway, thank you for taking up the short.
ശ്രീജിത്ത് ഉണ്ടോ? ശ്രീജിത്തെ ക്ലോസ് ചെയ്യാം. ശ്രീജിത്ത് ഉണ്ട് ഇല്ലേ?
ഇഷ്ടപ്പെട്ടതായിരിക്കും.
ഓക്കെ,
കുഴപ്പമില്ല. അപ്പോ താങ്ക് യു.
ഓക്കെ, താങ്ക് യു സർ. താങ്ക് യു ഓൾ.
ഗുഡ് നൈറ്റ്. ഗുഡ് നൈറ്റ്. എല്ലാവർക്കും ഗുഡ് നൈറ്റ്. ബൈ.